So thank you for asking me to present my poster, A Different Depression. My name is Duncan McLauchlan. I'm a neurologist and senior clinical research fellow in South Wales. So we know that depression is common in HD with rates of between 30 and 70% and is the most major effects in quality of life of any of the clinical symptoms of the disease. We also know that depression in HD is likely to be a direct effect of HD neuropathology, as studies in an at-risk population blinded to their gene status have shown higher rates in gene carriers. However, our knowledge of treatment efficacy and mechanism is derived from studies of depression in the wider population. In this study, we use propensity scoring in the Enroll-HD dataset to determine treatment efficacy of different antidepressant classes for depression, and use a neuropsychological test battery to determine the cognitive mechanisms underlying depression in HD. In study 1, antidepressant efficacy in HD, we included all adult gene-positive HD subjects started on an antidepressant medication for a depressive indication. The intervention was antidepressant class, and we used separate classes for SSRIs, SNRIs, and tricyclic antidepressants, and also separated out tetracyclic antidepressants such as mirtazapine, phenylpiperazines, noradrenergic, dopaminergic, reuptake inhibitors such as bupropion, and everything else we include is unique. Our outcomes were depressed mood, had scored greater than 7, or PBAS depressed mood scores, both greater than 1 at first follow-up for primary outcome and at all follow-ups for the secondary outcome. Propensity scoring uses an observational data set and includes known variables to determine the probability of being allocated different treatment to develop a propensity score. This propensity score is then included in a model of treatment efficacy to determine an unbiased effect of treatment. So we use the Twang and SurveyGlim packages in R to do this. So they use machine learning to determine the model for the propensity scoring and then give an assessment of the efficacy of the process so that any remaining variables not completely equalized by propensity scoring can be included in the model of treatment efficacy in a doubly robust approach. And we used demographic variables, psychiatric variables, and disease variables in this modeling process. For the cognitive mechanisms study, we recruited 51 gene-positive adult patients and 26 controls, familial controls who were gene-negative from the South Wales HD service. We took a medical history of verbal fluency and a motor assessment, as well as the HADS and apathy evaluation score, and then conducted a neuropsychological task battery based on the RDoC criteria of positive and negative valence. We used assessments of motivational anhedonia, looking at reaction time with incremental reward, which is an established instrument. We used an established measure of learning from reward and punishment, the probabilistic selection learning task. Where we used the reward subscale from the BISBAS questionnaire for consummatory anhedonia, and we developed a novel assessment to look at response to negative outcome. So we asked participants to watch a race, asked them how likely they thought it would be that they could speed up the slower runner, let them have an attempt by rapid tapping corrected for the reaction time, after which the slower runner would lose again, and then ask for their calculation about having a second go. We compared group effects and also assessed the effects of HADS depression score using generalized linear mixed models for the RRTT, and everything else used standard regression models. In study 1, antidepressant efficacy in HD, antidepressant prescriptions were very common for depression, so 37.71% of participants received one. SSRIs were the most commonly prescribed drugs, and in terms of bold figures, both the SSRIs and NDRIs were most likely to be free from depression at first follow-up and at all subsequent follow-ups. So this is our primary outcome data and uses SSRIs as a comparator and looks at all other treatment outcomes. And in this, the initial process, both phenylpiperazines and trend level effects for SNRIs, a unique class of drugs, were inferior, so they were more likely to be depressed at follow-up. The doubly robust model, so including all the variables, completely equalizing all variables, confirmed that actually SNRIs were inferior to SSRIs, as were the unique class of drugs. On our secondary outcome, there was an effect where NDRIs were actually superior to SSRIs and all other drug classes were inferior. However, on the doubly robust model, this effect of NDRIs as being superior to SSRIs was only present at trend level, whilst SSRIs were superior to SNRIs. On our second study, the cognitive mechanisms of depression in HD, we found that motivational anhedonia, HD cases were slower than controls. The HADS depression score showed slowed reaction time for reward, but there was no effective apathy score. There were no great differences or effects of the HADS depression score on reward learning. However, HD cases actually had worse punishment learning scores than controls and showed an association with the apathy score. However, inclusion of relevant confounders did not result in a persistence of this effect. We did not find any effects to suggest consummatory anhedonia. And finally, we found that HD patients had lower estimates than controls, but no association was seen with the HADS depression score. So antidepressant efficacy differs for depression in HD compared with that in the general population, where SSRIs and probably NDRIs outperform other agents. These agents have specific effects on motivational anhedonia, which is the core process underlying depression in HD. Thank you for watching this talk. I'd like to thank our funders for funding the study.